Hi everyone, this is Randy Nolf, and just wanted to welcome everybody to the webinar. We're going to wait a few more minutes just for a few folks that are logging on here, so we'll give it about 30 seconds and then we'll get started. Okay, so give everybody a chance to get logged in. As I said, my name is Randy Nolf. I'm a practicing periodontist in Stroudsburg, Pennsylvania. So welcome to tonight's presentation by Dr. Ross Lambert, Increasing Practice Revenue, Learn What Others Won't Tell You. So let's get started. Ross Lambert is a longtime friend and colleague, and you can see his list of accomplishments and training. Ross and I we trained together at Temple University in dental school and perio training. We taught together at Temple Graduate Periodontology. Ross is a practicing periodontist, was in solo practice, now practicing in a group. He's an educator. He's a consultant. I think Ross is an innovator, and he's also an accomplished businessman. He's an enjoyable speaker and always with some surprising information, which we listened to the other night, and we had some questions, but Ross never ceases to amaze me with some of the things that he finds in literature. You can also see on his list of accomplishments that he's a civic-minded person. At the conclusion of Dr. Lambert's presentation, I'll have a few comments about some changes that are taking place in the dental industry, and they're all essentially invisible to dentists at this moment. And I'll also take a few minutes to discuss a discovery we just made about direct-to-consumer marketing for GPs and periodontists. During the presentation, you can submit questions via email during the presentation, but we will be respectful of your time, and we're going to end on time. End as scheduled. So any questions that go unanswered, we will be answering by email. And you can also just reach out directly to me or Dr. Lambert. Our contact information will be listed at the end. So I just wanted to say before we got started that these are exciting times with great opportunity as the profession and new models of care develop. Dr. Lambert's going to introduce some concepts that you can apply immediately. We will be doing more web presentations to help you implement these. So without further delay, I want to turn the presentation over to my friend, Dr. Ross Lambert.
Thank you very much, Randy. Appreciate it. Good evening, everyone. And Randy, thanks for the kind words. And I'm going to shoot it right back at you. Randy is also an accomplished periodontist in the greater Philadelphia suburbs, I guess, eastern Pennsylvania area, and we've been working together and friends for over 30 years, and are always chatting about innovative things and things that are going on in the profession. So again, thanks for the introduction, and I'm going to get right into the material. Again, we want to respect everybody's time. We're not going to keep you for more than an hour here, and I think you're going to find what I have to say interesting, thought-provocative, and productive. First of all, what are the objectives for tonight? Number one, we want to improve the quality of care in your practice, and we want to dramatically increase revenue. And both of those things go together. Sometimes, you know people in the profession who are only interested in money, and then there are also an altruistic group that are only interested in the altruism of making patients' health better. But I have found that they both go together. The more you improve the quality of care in your practice, the more your revenue will go up. They go hand in hand. If we are the best professionals, the best doctors and dental hygienists that we can be, the money seems to take care of itself. So how are we going to do this? How are we going to improve the quality of care in your practice? And how are we going to dramatically increase revenue? And that is, we're going to introduce, I'm going to introduce a couple of things that I am recommending to my friends and my colleagues and my clients, the people that I consult for to dramatically increase revenue in their practice, primarily from the treatment of periodontal disease. And again, we'll talk a lot about that. But I have a larger list of objectives. Number one, we are way beyond soft tissue management. Soft tissue management came along in the 80s. It was a great thing. It got a lot more people treated. I'm going to give you some shocking statistics about that, however. We're going to talk about the recognition and identification of periodontal disease. There is a new paradigm emerging here, and the paradigm is metrics. It's all about numbers. I don't mean production numbers. The way we get paid and the way we will be paid on into the future is going to depend upon some sophisticated metrics. It's been my experience that our insurance carriers are always trying to find a way not to pay us, and unfortunately this may be another one. So we need to be on our toes, we need to be up with the latest, and we need to get ourselves documenting the right things so that we are sure that we and our patients get paid for what we do. A lot of this metrics, a lot of it revolves around what we refer to as risk assessment and evidence-based principles. I'll go into that in a few minutes. With that will come some referral guidelines and some medical legal issues. I want to talk to you a little bit about having a protocol, how to adapt to what I'm going to describe to you in the office, how to attract new patients, and I know Randy made some reference to that, so he has something for that. And I believe that if you apply these principles, that you will create a multiple six-figure increase in production in your practice. As far as questions and answers go, again, to respect everyone's time, we're going to ask that you jot your questions down and then email them to either myself or to Randy, and we'll be sure to get back to you very quickly with an answer to any questions you might have. I just think it's easier and cleaner that way, and it'll take a lot less time. Okay, are you ready? This is a clip from A Few Good Men. If you remember the movie, Tom Cruise and Jack Nicholson starred in that movie. It was an excellent movie about the Marines and the Navy, and obviously Guantanamo and things like that. And Jack Nicholson said, he asked Tom Cruise if he wanted the truth, and he said, I want the truth. And Jack Nicholson says, you can't handle the truth. So the question is, can you handle I hope you can handle the truth about what I'm about to tell you, because it shocks me, and I think it will shock you. Okay? First of all, in dentistry, I hope you recognize that things have changed. There are some operatories out there that still look like the one on the left, but most of us, hopefully, are in the new age of dentistry. We're into digital radiographs. We're into so many things, lasers, computers, etc. And if you're not up with that, then you're behind the times, and there are still plenty of practices that don't have a lot of modern conveniences. But I like to describe us as Klingons. We seem to cling to things that we were taught or what we've heard or what our colleagues tell us. We just continue to cling to things that are just not correct. Things that we learned in dental school, and for me, dental school goes back 40 years. But the things that we were taught in dental school are not true today. I was taught that implants don't work, that they are impossible, and anyone who's doing them is a heretic. So things have changed. So many myths that we still believe are out there. The average housewife, the average mother thinks that sugar causes caries, and we all know that that's not the case. The average physician will tell you that if you have high cholesterol, you should stop eating cholesterol-rich foods. That is incorrect. Many studies have shown that that is wrong. If you don't believe me, you can go on to the internet and Google that, and you'll see that I'm telling you the truth. It's your body's serum cholesterol is not related to your dietary cholesterol. To some extent, but to the great extent it's not. Carbs are not necessarily bad for you. There are good carbs and bad carbs. We all believe, everybody seems to believe, we are what we eat, and that may be true to a small extent, but a lot of disease has to do with genetics. A lot of disease has to do with body chemistry, and only part of it's due to what we eat. And again, I don't have to tell you this, but there are so many myths out there. Most doctors still believe that unchecked gingivitis advances to periodontitis. Those two diseases are distinctly different. They have distinctly different bacterial profiles, and quite frankly, asking, does gingivitis advance to periodontitis? The answer is, well, if you have periodontitis, I'm sure that you had gingivitis. That's like asking a heroin addict, did you ever smoke marijuana? So if he says yes, does that mean that everybody who smokes marijuana winds up being a heroin addict? I don't think so. One has really very little to do with the other, but anecdote and what we believe is that gingivitis advances to periodontitis. Sig Sokransky, famous Harvard researcher, has shown us that that's actually not true. I already told you about the myth that dental implants do not work. Dental implants have become one of the largest and most successful areas of dental practice today. You know, hygienists, for years and years and years, we beat our patients to, you know, perform excellent oral hygiene. We still think it's important, and it is important. But can you control periodontitis with excellent oral hygiene? And I have news for you. If you have periodontitis, you have pocket depths that are 5, 6, 7, 8 millimeters deep. Well, if you can show me an oral hygiene device that's going to get to the bottom of 5, 6, 7, and 8 millimeter pockets, you and I need to invest a lot of money together and develop that device, because that device doesn't exist. It's impossible for a patient to reach the bottom of deep pockets in periodontitis, and that's part of the reason that periodontal treatment is necessary. That's part of the reason why the disease is unchecked for so many. Scaling and replanning alone will not control period disease, yet many of our dental colleagues believe that scaling and replanning is the be-all and end-all of periodontal treatment, and I want to talk a lot about that in a couple of minutes. So the myths are out there. All right, let's get ready for the facts. The facts are shocking, and I hope you can handle the truth. I think most of us know that over half of Americans suffer from some kind of gum disease. Over 64 million adults have periodontal disease. Now that map is not meant to show that the lower half of the United States has more periodontal disease than the upper half. Picture that map as like a glass half full or a glass half empty. About over half the population has periodontal disease, people who are over 30 years of age. Well, that's not really that new. That's older information, but it's still true today. Here's the shocking part. Less than 7% are being treated. I'm going to speak to that point in a moment. Roger P. Levin, who I'm going to mention again in a moment, Roger P. Levin did a study about 4 or 5 years ago on a cross-section of his clients and other general practices around the country, and found out that 73% of all dental practices do not probe. They don't do periodontal charting. In the same study, he showed that over 50% of the charts of the patients that they looked at in these practices, they could not produce a current full mouth series of radiographs, meaning 5 years or newer. Well, to me, I mean, both of these things are shocking. The real shocker is going to come in a minute. But these are shocking, and I'll tell you why. We're in practice to improve and try to idealize the health of our patients. All of us have that emotion, I'm sure. We're also in business to make money, and there's nothing wrong with that. We're all entrepreneurs. We're all small business people. We perform services, and we get paid for them. Well, wouldn't you want to perform as much service as you possibly could? Wouldn't you want to discover in a patient as much disease as you can, so that if we treat that disease, we maximize their dental health, and we also maximize the return to our pocketbook? Both those desires are fair. There's nothing wrong with that. Well, how can you do that if you don't have the information that you need to do it with? How can you find caries if you don't have a current set of x-rays? How can you find leaky crown margins without a set of x-rays? How can you treat periodontal disease if we're not examining to find it at all? So these are problems that have plagued us for a number of years, and I want to address that a little bit this evening on how to change that. And that alone, as you'll see in a moment, is going to increase your production tremendously. Scaling and replanning alone, even with a locally administered antibiotic, is not going to eliminate periodontal disease. It's going to help control the disease, and it's one of the tools that we use. It's called phase 1 therapy, but it's not phase 2 therapy. It's not endpoint therapy for patients with periodontitis. For patients with mild disease, very often scaling and replanning will arrest the disease. It won't eliminate it, but it will control it, and sometimes that's all the patients need. But we need to talk about how we determine that. And of course, I think you know that more than 90% of people at retirement age have some sort of periodontal disease. So we're dealing here with the #1 chronic infectious disease in the world. More common, actually, than the common cold. More people have periodontal disease than any other disease in the world. And it is an infection. There is no argument about infection. Now, it's not only the infection that's causing the disease. This is a complicated disease that's got a lot of things wrapped up in it. It's got immunity, it's got genetics, it's got bacteria, it's got anatomy, it has patient behavior. There are a lot of things that go into periodontal disease, and quite frankly, if I could figure this disease out, that would be good for a Nobel Prize. There are 4 journals of periodontics alone that are 4 major journals that are published every month in this world, and they've been published for more than 50 years. And no one has figured this disease out yet. And if you take a look at any, just pull any journal of periodontology on any given month, and you look at the titles, the research is all over the map. Now, I'm not saying that we're confused about it. What I'm saying is that no one's figured out the whole disease yet. It's very, very complicated. Studies estimate that nearly half of American adults have perio disease. Now, this is not my study. This is a study from the Centers for Disease Control and Prevention. This is from the CDC. Nearly 2/3 of adults over age 65 have moderate to severe forms of periodontal disease. I don't know if you knew that. Well, the shocking news, and this just blew me away, is that in a study that was done with Delta Dental, insurance data indicates that only 7% of the patients have had periodontal therapy. So when they run reports to find out what is being billed for by general dentists, of course not periodontists, periodontists are going to bill for periodontal therapy, but when you look at general practices, only 7% of the insurance codes were in the 4,000s. Now, that's got to disturb you. That disturbs me. Over 65% of patients over 65 have moderate to severe disease. 64% of all adult patients over 30 have some form of periodontal disease, and approximately 7% of people's insurance of people are receiving treatment for that disease. I got news for you. That is shocking and disturbing, and it's embarrassing. All of us should be embarrassed for our profession because this is a major disease. It's a major disease that has lots of implications. You know, the mouth is connected to the rest of the body. I don't need to remind everyone that periodontal disease has been associated with heart disease and stroke and low birth weight babies and diabetes and so many other diseases. Yet it's running rampant. It's a pandemic. Every patient needs some sort of periodontal treatment. Every patient is a perio patient. Even if they're healthy, they're a perio patient because that adult dental prophylaxis performed by your hygienist is some sort of periodontal treatment. Now, it may not get billed with the 4,000 code, but it certainly falls under the periodontal treatment area. Now, whether it's more complicated perio procedures, like scaling root planing or osteosurgery with bone grafting, people need some sort of treatment. There is, I cannot believe how many mucogingival problems and how much recession just gets passed over and ignored and undiagnosed. As a periodontist practicing in private practice for over 30 years, I have to tell you, patients, when we first started to practice, they were referred for full periodontal cases. Today, there's a lot of prescription procedures that are referred. Please perform a crown lengthening. Please perform an implant. Please, do this or do that. When these patients come into the office, I find tons of periodontal problems that these patients have, even though that's not what they were referred for. So there's a lot of disease out there. And the criteria, how a dentist decides on what the periodontal treatment plan should be for any given patient, should not be based on what the dentist sees, on what the dentist's clinical impression is. The referrals and the treatment plans need to be based on real, measurable numbers, metrics. And the results of treatment need to be based on metrics. They need to be measurable. And I have news for you, and Randy can enlighten you more about it, because he's an expert in that area. But I've got news for you. As time goes on, and I'm going to touch on it in a second, we will be asked for these metrics, and our compensation may depend on those metrics. So we will talk about that. I will tell you this, that an organized periodontal protocol in your office, an organized protocol, and I will share with you an organized protocol, will become a huge profit center for you, even if you're already performing periodontal therapy in the office. I've mentioned already that periodontal disease is associated with several other diseases, many diseases. No one is questioning that at this point. You can go on the internet and Google periodontal disease and heart disease, and you'll be reading for a month. Recently at a perio convention, this statement was made by Myron Nevins, who was a famous periodontist. The evidence linking periodontal disease and cardiovascular disease is strong enough that the risk should be discussed with patients who have gum disease. Several speakers agreed at a conference sponsored by the American Academy. So there is tons of evidence. It's all tied up in C-reactive protein, inflammatory markers. It's not necessarily, we used to think it might be the bacteria, but it's more about inflammation and the body's reaction to inflammation, and that's not the subject of tonight's webinar, so we're not going to go and spend so much time on it. Now, if you're confused about what to do, and if you're confused about periodontal disease, and you're confused about how to classify it or how to diagnose it, you're not alone. Join the club, because there's a lot of confusion out there, and the confusion is kind of based on how fast our specialty area is moving. Periodontal disease diagnosis and treatment is moving at breakneck speed. I finished my training in 1979, and from 1979 till now, very little of what I learned in my graduate perio program is performed today. The procedures are all different. Our instruments are different. What we do and how we do it is different. So we're moving very, very quickly. And since 1969, there's been 4 disease nomenclature changes. And I'm not going to go on this, but most of us who went to dental school in the last 20 years or so are familiar with really what came out of the 1969 World Workshop on clinical periodontics, and at that time they suggested a classification, and these subgroups were classified. You don't need to write it down. We can this is old information anyway. What happened is in the 1989, 1993, and 1999 they changed the classifications again and again and again until we have now a rather complicated but a lot cleaner and a lot more descriptive diagnosis and perio case types. There are really 8 basic case types that we all need to be familiar with. And there's nothing new, but it's just that we recognize that a periodontal abscess, for example, is not standard periodontal disease. How do you classify that? An endoperio lesion is not standard periodontal disease. How do you classify that? So ANUG is not the same as other necrotizing diseases in the mouth. So how do we classify that? So previously, that stuff was all lumped in. It's been broken out. And again, you don't need to memorize this, but eventually, when it comes time to classify cases, you will have a chart that you will need to refer to classify your periodontal cases. Okay, so what do we do? We're all confused. How do we approach this? And how are we going to accomplish these goals? First of all, we all have a professional responsibility. We took an oath When we graduated, when we became doctors, we have a professional responsibility to our patients to provide the finest and the most up-to-date possible care that we can. Previously, that involved an examination and a diagnosis, and then a recommended plan for treatment. But I think it's gotten a little bit more complicated today. We're going to talk a little bit in a couple of minutes about risk assessment, which is one of the center focal points of this webinar tonight. And I think it's going to become a standard operating procedure, standard of care, if you will. And I think that most of your insurance carriers, your third-party insurance providers, are going to require it. For example, think about this. Let me just give you an extreme example for yourself. If you had a patient that came in for periodontal treatment, and they needed scaling and replaning, and maybe they needed a referral to a periodontist for surgery, but they were an uncontrolled diabetes, and they weighed 450 pounds, and their teeth were covered with plaque, and no matter how much you try to teach them to clean their teeth, they always look the same, and they look like a bloodbath when you touch them with a probe. Is that patient a candidate for periodontal surgery? As a matter of fact, is that patient a candidate for any kind of periodontal treatment? Probably not, because that patient is demonstrating to you that they can't control anything in their life. They're not going to do anything that you ask them to do. So all the money and time and effort that you spend on a patient like that would probably go to waste, because they'd be right back where they started. Now, I'm using that as an extreme fictional example. What did you do when you looked at that patient? You see, what you did was you saw what is, but you also, your brain rapidly computed a risk assessment of your own, that this patient is not a good risk. They're not a good risk because they have this disease, because they can't clean their mouth, because they're obese, because they don't care, because they don't brush or they don't floss. There are so many things that go into that, but that's an extreme example. What I want to share with you is that what I am proposing that you do, and I am proposing for the clients that I work with, is that part of a perio protocol needs to be a complete risk assessment. And I'm going to share with you a phenomenal program to do that risk assessment in a minute or two. So, professional responsibility to perform a risk assessment, examine the patient in detail, make a diagnosis. Now, I'm not only talking about periodontal disease here. I'm talking about caries. I'm talking about defective restorations. I'm talking about mucogingival problems. I'm talking about TMJ problems, bite problems, orthodontic problems. Every patient, especially in general practice, needs to be thoroughly examined, unless they're coming as an emergency with pain. Then from the examination, a diagnosis gets made. Now, I was an engineer. You may have seen that on my opening slide. I was an engineer before I was a dentist, and I believe in systems, and I believe in a systematic approach to a problem. If the George Washington Bridge in New York is shaking, we don't examine the bridge with a helicopter from a half a mile away. You've got to get down and look at every nut and bolt and cable on that bridge. And you've got to examine it and keep a record of, screw number 1, bolt number 2, loose. Okay, so you've got to make a diagnosis from the examination. We have to obtain informed consent, actually, to even do the examination in the first place. Obtain informed consent, make a recommended plan for treatment, either treat them or get a signed refusal for treatment. And these things are medically, legally important, medico-legal importance. The informed consent is paramount. I am now obtaining informed consent for everything that I do, every procedure that I perform, including the examination, I get an informed consent for. If the patient doesn't want to do what I recommend, then they need to sign a form that says that I've been shown the treatment and I do not want to have it. Because otherwise, you may be held responsible unknowingly 4 or 5 years down the road. So we evaluate and record the results of the treatment. See, that's just as important, and I'm going to come back to that, and we make referrals as necessary. So I'm going to talk about breakpoints in therapy in a minute. Now, this is from 1992 in the Journal of the American Medical Association. This is 1992. This is over 30 years ago. And what they recognized in medicine was a new paradigm emerging. Evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiologic rationale as sufficient grounds for clinical decision-making. See, that goes on in dentistry all the time. We take a look at the patient, we think, well, I think they need this, or I think they need that, or this is swollen, or that's this. See, that is clinical intuition and experience, and they count for something. Certainly mileage counts, but where our profession is headed is we're right behind medicine. We're headed into a paradigm where the metrics, evidence, you need to provide reasons and proof, numerical reasons that can be measured in order to justify treatment. So when defects in an existing paradigm start to show up and they start to accumulate, and then the existing paradigm doesn't work anymore, then the paradigm is challenged and replaced by a new way of looking at the world. And that's what happened to medicine, and that's what's happening in dentistry. I'll give you a simple, silly example. When you go to your physician, they take your blood pressure. You know what your blood pressure number is, don't you? And they do your cholesterol. You know what your cholesterol number is, right? And they do your hemoglobin A1C, and you know what that is, right? And you know what your triglycerides are, right? Sure you do, because that's where medicine, you didn't ask for that 30 years ago. They were doing it 30 years ago, but you didn't ask about it, and no one else asked about it either. Now you can't get insurance unless your values are in the right place. So this is where the profession went in medicine, and we are not too far behind, and you're going to see it happening. This is Dr. Shah, the New York State Health Commissioner. This is a recent article. And the most important thing is if you can measure something, then you can improve it. If you can't measure something, how do you know whether you've improved it or you haven't improved it? That's the point. Data is the next national resource. That's a huge statement. That is huge. And it's going to be, trust me, it's following us into dental practice. So here's a couple of tools that I think are going to become very, yes, sir.
I think your mic is, you're having a little problem with your headset that we had the other day when...
Okay, I think it may be the internet connection.
I think so.
Sound okay now?
No, you're still kind of garbled. It just started happening.
Sorry about that. Hold on one moment for me. Good. Hang on.
You sound better already, Ross.
Okay, good. How's that? Is that better now? Randy?
Yeah, much better. Much better. Okay. I'm here. Yep.
Oh, okay, great. Let me just get back to where I was here if I could. Sorry about that, folks. I think it's, for some reason, sometimes the internet doesn't cooperate. So here's where we are. And I want to talk about the dental test and previsor.com. These are tools that bring the metrics into your practice. And the dental test, I believe, and I'll talk more about it in a moment, I believe the dental test is a tool that can be used to raise the awareness of the patient. I think it's, in my opinion, it will go viral and can be a tremendous source of new patients for you, and I'll explain to you what I mean by that in a moment. I would encourage you, this you can write down, www.thedentaltest.com. You can go there, it's free, and take the dental test yourself and see what it does for you. I'm going to show you what it does in a minute. I think that's very valuable. I think that we're going to want to encourage every single patient should take the dental test. I'm going to make a suggestion that you get yourself a laptop computer or a tablet that you can put in the waiting room and have your staff, have everybody sit down, take the dental test. It only takes a couple of minutes, right when they're in your waiting room, because it's going to raise patients' awareness, and it's going to make you look like you're really a super dentist, which I know you are. Provisor is another tool that's going to bring the metrics into your practice in a big way. Provisor is the risk assessment software, and you can go to www.provisor.com and register for a free 30-day trial of that software. And again, in my opinion, Provisor and programs, there'll probably be some competitors out there along the way in a few years. These are things that are going to become a necessary part of practice in order to provide the metrics that we need in order to deal with third-party carriers and other people who are examining us very closely. So I'll come back to both of these in a moment. This is the Provisor website, and you can see that on the left-hand side that you can get a 30-day free trial. If you go to the website, you can get a much more in-depth look at what Provisor can do for you. It's a tremendous resource in terms of teaching and clinical and academic information. I love it. I've been including it. I've included the Provisor software in my lectures when I lectured for Aura Pharma and traveled around the country lecturing for Reston and soft tissue management and non-surgical periodontics. I included Provisor in over 400 lectures that I gave around the country in a 5-year period while I was with Johnson & Johnson. This is a super piece of software, and it's really part of the focus of what we're focusing on tonight. This has the power here of creating a large increase in your bottom line, and I'm going to show you why. This is not just some mumbo-jumbo piece of software. This is a piece of work that's been a long time coming. There's a lot of scientific papers written about risk assessment. Roy Page out at the University of Washington did a lot of work with this. Person did a lot of work with this. These are our superstar, world-renowned periodontists that worked on this project going all the way back to before 2002, and Provisor is the culmination of many of their efforts, and it's a risk calculator that is very accurate in determining what your risk is for not only periodontal disease, but caries and cancer and other things like that. Now, what you have to understand is that doctors have a tough time separating disease and risk. They're two different things. Remember the example that I gave of the brittle diabetic who's 400 pounds overweight, who has horrible hygiene, etc. You can look at that patient and you can see their disease, but that's not their risk. Risk and disease are two different things. Disease is one thing. Risk is the third dimension. Risk is prediction. Risk is about the future. And that's what Provisor does based on a series of answers that the patient and the doctor provide. We get a scientifically validated risk score for periodontal disease, oral cancer, and caries. And that patient's treatment plan needs to take that risk assessment into account, like the example that I gave you. I gave you an extreme example of a patient who would be a very poor risk. So if you're the insurance company, and I'm not talking about now, but I'm talking about several years from now, if you're a dental insurance company, would you want to pay for expensive periodontal treatment for a patient like that? And the answer is no. And I think that that's what's going to happen based on the mix. So this is going to become a very important part of practice, and the practices that I work with and the people that I have recommended implementation of this have seen tremendous increases in their bottom line. I'll explain why in a second, because it's part of a protocol. It gets them organized, it gets them into the right direction, it gets them considering every aspect of that patient's needs, and it differentiates patients from each other, and it differentiates the treatment for what those patients will need. So bottom line on the very bottom of the slide is that it's just like the heroin addict I described to you. All patients with severe disease today were at one time healthy and disease-free, right? So using Previsor risk scores as an essential element in treatment planning can help to keep patients who are not yet diseased healthy based on risk, based on their risk scores, based on their behavior, what they do, and what is, we can calculate risk. Okay. Now the dental test, this is for patient use, and this is a terrific piece of software. And again, I urge you to go to dentaltest.com, take it yourself. You'll see what I'm talking about. This is what it looks like. It's a very brief 2-page questionnaire that you do right on the computer. How old are you? Do you have any missing teeth? Do you have any crowns in your mouth? Do your teeth hurt? How many teeth have you had filled? How many teeth have you had capped? How many have you had in the last 2 years? Do you have snacks between? Now these questions are just not made up, willy-nilly. These patients lead us to some conclusions, and we can instantly produce a little report card for you or for whoever takes the test that now involves the patient in their care. So by taking this simple test that takes 5 minutes, they get a report card on what their gum health risk, what their levels are, what their tooth risk, tooth condition, oral cancer, and what it does is it sets up the groundwork. It creates a base, it creates a basis for discussion. And if a patient comes in, takes this test online, and all of their scores are 5s, and they're upset, they're concerned, and they want to know why, this opens up the door for you. It opens up the door for you to explain. It opens up communication, and it takes them in the direction of the treatment planning and the high-quality examination, diagnosis, and risk assessment that I've been talking about for the last 15 minutes or so. Great tool. And here's, like I said, I would put a tablet or a computer in the waiting room and have your staff direct everybody to take the dental test, print out the result, and now you have something to start up a discussion about, and that leads them into the whole organized protocol and risk assessment. And what that does, that will improve the quality of your practice. It will make you look like you're a genius. It will bring you into modern times. It will impress the patient, and guess what? They're going to tell everybody else about it. They're going to tell their family about it. Hey, I went to the dentist, I took this dental test. Now, what we're doing, what I'm recommending to my clients is, number 1, implement Previsor. Number 2, I am recommending to the people that I work with that they should send out an email or a letter to all of their patients urging them to go to thedentaltest.com and take the dental test and discuss the results on their next visit. Okay, let's talk about an examination for a moment. I'm not going to dwell on what we have learned in dental school, and again, some of that isn't correct anyway, but certainly every patient needs a full examination once a year. At one of the, if they come twice a year for hygiene, at one of those visits they need a full examination. That doesn't mean that you have to, probe every. It doesn't mean you have to record every probing depth, but certainly the existing examination needs to be updated, and current information needs to be provided. Of course, informed consent, I mentioned I do for everybody, for every procedure that we do. Update their medical history. This risk assessment that I'm talking about, I think Previsor should be part of your protocol. A comprehensive oral and dental exam, including a head and neck examination, oral cancer examination, bite examination, perioprobing. Note the bleeding upon probing areas, because bleeding is the #1 indicator for periodontal disease. Mobility of the teeth, furcations, recession, lack of attached gingiva. A perio chart contains those things. Now, hygienists can do a lot of this, but the dentist needs to confirm that, and they need to take a look at these things. These are all things, this is all treatment that's sitting in the charts in your office that isn't being done Just by looking for these things, you will find that there is a ton of work to be done. Believe me, there is, with 7% of patients being treated periodontally. Radiographs, very important. I told you about Roger P. Levin. Couldn't find a full mouth set of x-rays in over 50% of the charts that were examined. Every 3 to 5 years for adults, vertical bite wings, switch to vertical bite wings. For goodness sake, get away from horizontal bite wings. You know, they're showing you caries, and they'll show you open margins in your crown and bridge, but they're not going to show you the bone levels that you need to be looking at. Vertical bite wings show both, and I would, you know, switch your protocol to vertical bite wings. All the current digital x-rays and computer programs allow you to do that. Panorex, in my opinion, is terrific for diagnosing impacted third molars. It's great for children with developing dentition, but for an adult, it doesn't really tell you much. You can't see caries clearly. You can't see periodontal disease clearly. You certainly can't make measurements for implants that are reliable on them. So for me, I know I'll probably upset the apple cart and upset some people. They're pretty much useless. I don't like pans unless you're looking for something, you know, large that periapicals are not going to show. Of course, yeah, periapicals you take as you need them. Radiographs, very important. This is a horrible panorex. I'm just showing you how distorted sometimes they are, and that's a very clear radiograph. And everybody, of course, sees the big perio defect where I'm moving my cursor right now. But do you see this defect? Did you notice that one? That's perio disease too. So you're not going to see that on a panorex. You might see this on a panorex, but you're not going to see that on a panorex. Okay, so what's the big disconnect that I'm talking about? Well, the big disconnect from my observation is that we started with soft tissue management in the mid-1980s. We got everybody on the bandwagon with the PSR. We got everybody on the bandwagon performing scaling and root planing. We got people on the bandwagon placing locally administered antibiotics. Where the big disconnect is that what happens after that? What happens after the scaling and root planing? Most practices are just putting their patients into recall. They're just putting them back into the hygiene program. Nobody is measuring what happened. That measurement, that re-evaluation examination after scaling and root planing is very important. It's a major breakthrough. It's a major break point, and it's a big disconnect in dentistry. That reevaluation should occur 4 to 6 weeks after scaling and root planing, and it should be a full mouth periodontal charting so that you can compare the new measurements to the old measurements. You got to be able to measure your success. And pocket depths that are still 5 millimeters or greater, those patients are not finished. They are diseased. They have periodontitis. They need advanced treatment, and they need to either be seen by someone in your office or you who is qualified to do phase 2 periotherapy, or they need to be referred to the specialist. Plain and simple. Big disconnect in dentistry, and I venture to say this is what's going on in most practices, which is why there's not a lot of perio treatment being done. Remember, scaling and root planing is very, very limited. This is a slide out of my old Arreston lecture provided by Charlie Cobb. Look at the tooth on the left-hand side. Obviously, it's a hopeless tooth. The tooth was extracted, but in all the years, and this was a perio patient, by the way, being maintained in a periodontist practice for many years. Treatment had been done, and they were being seen for scaling and root planing on a periodic basis. Well, I guess the scaling and root planing didn't do too well, as evidenced by the picture on the right. Well, that's just a fact. That's not because the operator was bad. You're just limited by the anatomy of the tooth. You just can't get everywhere, and those things are going to, to get that tooth. As surgical periodontists, I can tell you, and myself, and Randy will tell you the same thing, that when we do periodontal surgery, even when the best operator, the best dental hygienist, scales and root planes teeth, when we do flap surgery, there's calculus there. There's calculus that's left behind even by the best operator. And the calculus is the nidus of infection and the start of inflammation. And it has to be removed. So patients who have 5 millimeter pockets and greater after they've completed initial therapy, need to have periodontal surgery. We need to do something to control their pocket depths, and that is a big disconnect in dentistry. This is a slide from Sig Sokransky. It's not only a bacterial infection. Remember, there's a lot of other things going on here. We can't blame it all on the bacteria. There's a lot of things that go in to periodontal disease. The locally administered antibiotics are terrific. They're terrific for what they're terrific for. Bear in mind, I was the chief educator for Aura Pharma for about 5 years. Went around the country, didn't practice, delivered a lecture almost every evening to dinner groups of dentists, over 400 of them. I'm a big believer in locally administered antibiotics. However, they do not grow your bone back. They are wonderful for patients who have 4 and 5 millimeter pockets at the outset, and you'll find that those patients improve. If you put this in patients who have 5, 6, 7, 8, 9 millimeter pockets, yes, you'll reduce their perio infection. You'll kill off the bacteria, but that's not going to grow their bone back. It's not going to take a 7 millimeter pocket and make it 3 millimeters. It just isn't. So these things are they're an adjunct to initial therapy, but they're not endpoint therapy. Don't think that because you're putting in a locally administered antibiotic that you're solving the problem. It's an adjunct. It's not a solution. Reevaluation. It's the metrics that count. It's the measurements. Most of you are already seeing your dental insurance carriers asking you for perio pocket depth charting for lots of different kinds of treatment. I had to provide today, just today, we were asked to provide a full mouth periodontal charting for a dental implant predetermination. They didn't want to see the periodontal charting around the area. They wanted to see the whole mouth. Why? That insurance company is evaluating what the future is for this patient. Is this patient worth a dental implant here? That's what they're trying to find out. What's the condition of the rest of the mouth? Just as important. So reevaluation, record the metrics so that you can measure your results. Now, I think everybody's familiar with Roger P. Levin. He's one of the most well-known and most successful practice management consultants in the country, if not in the world. Roger is a prolific writer. He writes in many of our dental journals almost every month. He's a pretty smart guy and a very personable guy and a very good businessman. And he has looked at Previsor, and he says that Previsor is the one system that can grow your hygiene department by $100,000 to $200,000 a year or more. And we could prove that. Just the increase in adult recalls based on doing a risk assessment and a proper reevaluation, just the recall production, going from twice a year to 4 times a year for the patients that need it, and other periodontal treatment and scaling and root planning that some of these patients need, just the adult recall production alone is a huge increase. Previsor is simple, it's inexpensive, and it's immediately profitable. And this, again, is from Roger Levin when he describes Previsor. It's simple. You got to know how to bill it, though. We'll talk about that in a second. It's inexpensive. It only costs a few dollars a day to have. And it's immediately profitable. It will not be overhead for your practice. You're not going to make an investment in Previsor software, which is inexpensive anyway, and lose your money. It's going to work for you. It will be instantly profitable for your practice. Now, what's required by the Previsor system? Well, things that place the patient at risk. We're evaluating risk. You'll see the questionnaire in a moment, but things like age, smoking, diabetes, history of surgery, pocket depths, bleeding upon probing, restorations that are below the gingival margin, root calculus, radiographic bone height, furcation involvements, vertical bony lesions. These are things that are recorded by Previsor in a questionnaire that gets filled out, and there's various versions. This may have been a little older version that we have. The point is that it asks these things, and it's very simple input. It's about 28 keystrokes that are required here. It's computerized now. It looks more like a checkoff sheet, but it's computerized. And these things are divided into areas of risk that are recorded. we ask some questions. We fill in the data. Deepest pockets in each section. Which ones bleed? Is there bleeding in that section? We take a look at a good set of radiographs and get an estimation, but a reliable estimation of the distance from the CEJ to the bony crest, usually taken on bite wings, because those are the most reliable x-rays for measurements, because they're taken at, at a perpendicular angle. And we input the data, and out comes beautiful reports. Patient report and a doctor's report. The patient is getting a report card. They're getting a report card that looks a little bit like the dental test, but in a lot more detail. And based on the answers to the questions and based on the data that's input to Provisor, it calculates, an algorithm calculates what their risks are. And in this particular case, the risk of gum disease was a 4 out of 5. Pretty risky. In this case, they got a score of 30, which is moderate gum disease. But more importantly, it starts to talk to the patient about the report card. Obviously, Mrs. Jones, or in this case, Mr. Thompson, we want to reduce your scores. We want to reduce your risk, and we can do that by changing behavior, changing certain things about your dentistry, and we may need to do the following things. This is the active intervention that you may need in order to help solve these problems and reduce your risk for future disease. Now, what is this? This is a machine telling the patient what you are going to tell them, what the hygienist is going to tell them, what the rest of your staff who are on board are going to tell them. When multiple people tell patients the same thing and you have metrics to back it up, this becomes very believable for them. They become part of the treatment and they go along with what you recommend. So we want to reduce your pockets. These are the things we may need to do. Okay. Now you need to know how to build these things too. And we talked to you about how to build these things. That's one of the things that I do and that Randy does when we deal with clients who are implementing protocols and implementing the Provisor and the dental test is how do you build this? How do you set up the protocol? How do you maximize your remuneration? And that, quite frankly, is a subject for an entire webinar on its own, which will be coming in the future. But we will help you with that as we move along. Now, all the codes have changed, the CDT codes have changed recently. I am a great believer, and always have been, that the insurance company should not be dictating treatment for our patients. We decide the treatment for our patients. So if it's not covered by dental insurance, it just means it's not covered. It doesn't mean we're not going to do it. I have found, after many years of practice, and even when I go into practices of various different types of patients, high socioeconomic, low socioeconomic, patients come to you because they trust you. When you tell them something, when multiple people tell them something, when a machine tells them something, they believe it, and they will want it, and they will pay for it. See, my opinion is the Provisor risk assessment should not be, moving forward, should not be an option to the patient. And I believe the patients will pay for it. We've seen that in our practice when we do oral cancer screenings with an oral cancer screening device, whether it's a light or a dye or whatever you use. Many patients, if you recommend it, will say yes. So if you recommend Provisor, they're going to go with it. And it's a terrific piece of software that gives you great stuff. Now, these are new codes, and again, I don't want to dwell on each one, but there is a notice that if you just read here, and I'll show you where I'm talking about, disease assessment reports. If you submit your Provisor reports for these codes, it's going to bolster the insurance company's confidence in you, and the examiner may allow payment for some of these procedures. These are newer procedures codes, and hopefully you're familiar with them. If not, don't worry, don't write them down, don't scramble to copy all this down right now. We can provide this for you. If you want this, just email us and we will give you what we think you should be doing in terms of examination. These are examination codes. I have a whole periodontal protocol that I have written and designed, complete with insurance code numbers. And notice that periodontal risk assessment is part of that perio protocol. That previsor risk assessment is part of the perio protocol. And I believe the patients will pay, and in some cases I think that third-party carriers will pay as we move forward into the future. Now, this is, protocol number 1. This is for the periodontally healthy patient. I have protocols for all the patients, for all 8 types of patients, and I'm happy to share that with you as we move along. All right, so don't be confused by all this. This is not, believe it or not, this is not complicated. It's just different. Now, the key here is to get started, is to do something. Albert Einstein said every action has an equal and opposite reaction. And in physics, that is true. My statement is no action has no reaction. So if you don't change anything in your practice with risk assessment and with the treatment of periodontal disease, next December 4th, you will be doing the same thing that you're doing today, and you can pretty much count on your bottom line being the same thing as it is today. If you want to improve your bottom line, take my suggestion, improve the quality of care by including risk assessment and a periodontal protocol in your practice. You can make 2014 a breakout year for you. You could change everything in your practice and get excited all over again about being in practice. But here are some keys. You got to go all in. You can't just do part of this and expect it to work. And you may need help. Ask for help. You may need us. You may want one of us to consult with you and help you with it. And we're available for that. That's not what this webinar is about, but we are available for that. You got to go all in. You got to make up your mind that you're going to do this. You got to stick to it. Furthermore, you can't pick and choose. Make every patient part of it. Make every patient take the dental test. That's free. Have patients participate with Previsor. Do a risk assessment. And what you charge for that, and what, that's up to you. You can either do it for free or you can charge a fee for it. I believe patients will pay for it. You yourself should register at www.previsor.com for a 30-day free trial. Why not? You'll see how valuable it is. You yourself should take if nothing else, take the dentaltest.com yourself and have all your patients take. It's going to make a difference, trust me, because it's a great piece of software. Every staff member in your practice has to be involved. Every staff member. The hygienists have to be on board. Trust me, it's going to make them a lot busier than they are now. Maybe they don't want to be busier, I don't know. But every staff member, from front desk, assistants, expanded functions assistants, hygienists, everybody needs to be on board with this. And you can do what you want, but in the practices that I consult with, if the staff member is not on board, then they can't be on board. They need to get out. They need to leave my practice, because everybody has to be in this together. Understand that this is good stuff. This is the right stuff. This is the stuff moving into the future that patients need. Get and adopt a perio protocol. It doesn't have to be mine, but it needs to be modern and up with the times. And again, ask for help. I'm available for help. My email address is gummydoc, not gummy bear, gummydoc@gmail.com. And hopefully this webinar has made some light bulbs go on for you. Hopefully it's getting you a little bit excited about what we're talking about. Certainly it's got me excited. I'm excited to see our participants excel and make 2014 a breakout year. So with that, this concludes my portion of the webinar. Stay tuned for future webinars that we're going to have. Our contact information appears on the screen right now. Dr. Randy Nolf and myself, please feel free to email us any questions you might have from tonight's webinar or any other information that you might want from us. We'll be happy to help you. So with that, I'm going to turn the mic over to my good friend and colleague, Dr. Randy Nolf, for a couple of closing comments that he has. Randy, are you there?
I'm here, Ross. Thank you. That was excellent. We're kind of up against our break time, so I'm not going to really require a lot of time here. I just had a few comments that I prefaced the presentation with. I wanted to make a comment about the changes that are occurring in dentistry. Our friend and colleague, Dr. Mark Cooper, is a periodontist and prominent consultant to healthcare and industry in general. And he says that dentistry always follows medicine. Well, what's been happening in medicine is being driven a lot by employers. Employers have adopted wellness models in their healthcare, and they've been rewarded. They've been saving money, and they've been bending the utilization curve down through wellness. So now they're demanding the same wellness models to be made available and utilized in dentistry. It's just that up until recently there was really no way to do a wellness model through any type of plan in dentistry. So now the plans are being written, and they're based on risk algorithms. That's why this is such an important topic, and it is going to lead the industry as time goes forward. It opens great opportunity, but for the most part, dentists aren't able to see this yet. It's really kind of invisible. It's a force that's gathering outside of the profession. And we're going to be doing more web presentations to help you implement these new paradigms. We'll be scheduling some web presentations that include industry leaders that really are seeing this from a higher vantage point and can give you some insight that is really quite revealing as to what's going on. For instance, there's a statewide adoption for Medicaid population that will employ a risk assessment protocol. I can't tell you where that is. In fact, maybe when we have our webinar, they will be able to announce which state is doing that. I can say for sure that employers in New England have adopted plans that actually reward the employees for risk assessment online and then followed by risk assessment verification with a dentist. Now, I also said in the beginning that we had discovered some direct-to-consumer successes just recently, and I can share those with you. We found that patients will take an online dental test. They actually love taking online tests. It took us a while to figure that out, and it's not the topic for our webinar, so I'll just mention it. We found a Facebook strategy that actually works wonderfully to have patients take the dental test and then contact us for a follow-up. So anyway, these things are happening. We would love to talk to you more about them. You could reach out directly to me or Dr. Lambert. We'll probably send you a follow-up shortly with some future webinars planned. So at this point, I'm going to just say we've enjoyed the presentation from Dr. Lambert, and I hope you did too. So at this point, we're going to conclude and sign off. So I hope to talk to you soon.